Thank you for inviting me. Thank you, Dr. Krishnaruk and Dr. Borecki. Thank you, Henry, for the invite. I'm delighted to be here. I'm going to talk to you about a project that actually several of us on this panel are involved in. And for the first part, so Dr. Senathirajah and I have divided up the talk. I'm going to provide you with the background, and she will get into a little bit more of the visualization and technical side of things. So the name of the talk is Data Visualization Need to Support Emergency Response to COVID in a Safety Net Hospital. So just situating us somewhat. So I live and work in central Brooklyn. I'm originally from Montreal, Canada, and we'll come to that story in a moment. So central Brooklyn is a population that was hit exceptionally hard by COVID. Now, I fully understand that people all over the world were hit very hard, but we were among the highest in the first phase. We had a very high death rate, a very high infection rate, and some of those problems still persist. Obviously, things are very different today, but those are some of the challenges. I work in a small independent safety net hospital. I'll talk to you about what all those things mean. It's in a lower resourced area, and frankly, in a lower resourced hospital. So those are some of the challenges. So University Hospital SUNY Downstate is the only academic medical center in Brooklyn. It's a city of 2.6 million. I think that would make it the third biggest city in Canada. It's a medically underserved county, a safety net hospital, and we'll talk about that. It was designated as a COVID-only hospital, only one of 3 in New York State. The pandemic had a really dramatic impact. Surgery and other cancellations, chemotherapy and so forth. Hospitals in the United States rely on their revenues, and this resulted in significantly decreased revenues. Central Brooklyn has one of the highest rates of deaths, comorbidities, for example, hypertension, diabetes, low levels of insurance. At the time of our first phase of data collection, New York City accounted for almost 70% of New York State's total cases. We have an interesting contrast. So we're focused mostly on downstate, which is in central Brooklyn. We did a comparison with New York Presbyterian Hospital, Columbia University, where Dr. Cato is situated. They're very different institutions, of course. New York Presbyterian is much larger, better resourced, and these were very informative comparisons. So what do we mean by a safety net hospital? It's a designations for hospitals set up for populations who might not otherwise have medical care. They may be refused medical care. So the patients are often poor, underserved, sometimes rural or other areas, which makes it harder for them to have access. So University Hospital of Brooklyn is one of the most underserved and diverse counties. Now, what is the analog? There isn't really an exact analog, but I grew up in Montreal, and you have large hospitals. Now you have even larger hospitals because you now have the McGill University Health Center, and you have, in the French system, you have those hospitals. But when I grew up, you had Royal Victoria Hospital, Montreal General, Jewish General Hospital. These are all very large hospitals. But, you know, I lived in the north part of the city, just a little, not too far from an area called Laval. And there were small hospitals, and they were not nearly as well resourced. And of course, that's the case all over Canada, and more in some regions than others. So that when you think of the comparison between an independent hospital and safety net hospital, I think that's a reasonable comparison. So we have 3 set of aims in the project. And can somebody let me know when we're at the 10-minute mark, please? So we want to know how the workflow changed. So we're particularly focusing around information needs and thinking about ways to support them and visualize them, but we're also situating it. we're also situating it in a broader context. We're looking at applications, roles, tasks, communication, tools, decisions, sequence of activity, all facets of organization, clinical flow. And this has preoccupied the first year of the study. We're now in year 2. So Dr. Kenrick and Dr. Boricki are leading the charge on AIM-2. They're looking about ways to model these changes to identify adaptation challenges, barriers, and stress points. Dr. Raja will talk HIT solutions and stress points and how we improve pandemic response and overall emergency management. We're still at relatively early stages in AIM-3 that involves a lot of negotiations with hospital leadership. We've been involved in discussions for months. We're making incremental progress, but it remains quite challenging. So a current focus is barriers to address information needs and solutions related to them. We're looking at ways to reduce regulatory reporting burden. This is an enormous problem in New York State in the US, but it's also reportedly a significant problem across Canada as well. And that's how do hospitals meet the public health response? It turns out to be very challenging. And a lot of these are informatics issues. A lot of these are data science issues. There are also broader organizational issues. So for example, how do we support better data extraction? So we know at our hospital, there's a lot of manual extraction that goes on. And so we're endeavoring to create visualizations to support decision-making. And we made some progress in that way. And also looking to leverage other informatics solutions. So we've done a total of 52 interviews. At the risk of sounding a little bit self-serving, they've been really compelling. People have really interesting stories to tell. And we've looked at different facets of hospital response, from emergency response team to infectious disease, to pharmacy and lab, respiratory therapy, and so forth. We've done a small number of observations, and we have an ongoing survey. So we could divide up the areas. So there's some generalizations that apply hospital-wide. So everybody needs to know a bed count. How many patients are in the hospital? Turns out to be a harder problem than one would think. But if we look at particular areas, like emergency response team has both general needs and specific needs. Vaccination workflow is a very unique problem that we're looking at. Infection control is kind of ubiquitous. It's tremendously important. The hospitals poured a lot of resources into it. If we had better tools, better visualization tools, better data analytics tools, there'd be much less manual work done. So people in infection control, actually clinical staff, have been repurposed to manually gather data because there's a tremendous requirement and it's tremendously time consuming. I'm only going to talk very briefly about that because I know I have a short amount of time. So we have embraced an institutional resilience framework. It's sort of a theoretical underpinning of what we do. And we have a particular model called the SIPES model. You might be familiar with it. It's a system engineering initiative for patient safety model. It's widely used in human factors in healthcare. I won't say too much about it, but I'm happy to answer questions. And so we use this as a beginning framework to do different kinds of analysis. For example, coding in the interviews, which we've done. We've coded all 52 interviews. And we look at different kinds of tasks, tools and technology, person domain, etc. And these map onto our modeling goals that Dr. Kenrick and Dr. Boricki are working on. By the way, some places are more or less formal. So some people, anyway. So some of our high-level findings: hospitals were tremendously burdened with data reporting requests. And I've got to move Zoom out of the way. Hospitals did not always have access to necessary data. That's true worldwide. And information to promote situational awareness, what's going on in the hospital. How do we get a sense of that? This is a key component to effective emergency response and resilience. Hospitals underwent reactive changes. So I think no hospital in the world was fully prepared. We were significantly underprepared, even though we put a lot of resources into planning in the months leading up to the pandemic. So there was a lot of reactivity. A very important observation, and maybe obvious in some sense, but the implications are not obvious. Not all hospitals have the same HIT capacity, resources, and infrastructure to meet the intense data and information demands necessary for effective pandemic response. That is certainly true. I've read a little bit about this situation in Canada, and I think that applies. It may not be as dire. The institutional inequities are probably not as great, but I think they're pretty significant, particularly in certain regions of the country, particularly in Aboriginal populations and so forth. So there's a tremendous amount of reporting to different agencies in the US. I assume that there are a lot of parallels. It works a little bit differently, provincially and federally in Canada. But you have all these agencies. They require interacting with different databases, different reporting systems, sometimes the same data. Sometimes it's the same data, but it's a different name, or the variable is different in some ways. All of that lends itself to very significant complexities. Somebody needs to tell me how I'm doing on time. My timer stopped. Very quickly, this is a really interesting report that came out at the end of last year. It basically is very much parallel with our conclusions. This is Vision to Transform Canada's Public Health System, came out in December of 2021. Talked about COVID inequities, and of course we see a lot of the same things. They're maybe a little bit more dramatic in the United States, but they're parallel. So, Indigenous people in lower income groups were likely to be exposed to the virus, and this is due to circumstances such as crowded housing or inability to work. So individuals in these groups were more likely to be hospitalized or die if they tested positive for the virus. And this, of course, relates to social and economic inequities, many that have problems that have been around for at least decades, perhaps even longer than that. So they also argue for a stronger public health response. This exactly mirrors the challenges that we're having in New York State. So the delays or gaps in data, misinformation, rapidly evolving evidence. People really didn't understand COVID-19 when it started, and there were no guidelines, and that evolved rapidly. And it was very, very hard to synthesize all that. Of course, demands for PPE, public health, workforce burnout, which unfortunately we're still living with. Oh, 10 minutes are up. Okay, not doing that badly. Okay, thank you. So there's a need. So, hospitals basically reacted to changes. They were highly reactive. So they put in place short-term solutions. So they redeployed personnel. They went through a lot of different kinds of changes. Some of it worked, much of it didn't. All of which created significant stress. In a lot of cases, they didn't have the data or evidence needed to make informed changes. So there's really a need for lasting solutions so that health systems can continue to tackle COVID pandemic, but also address other pressing public health priorities. So infection control in hospitals have very important responsibilities, and they, nationwide, there's been a dramatic increase in hospital-based infections, I think for the first time in something like 20 years. So that is a significant problem. Dr. Senathirajah will talk a little bit more about that, but we've been tracking the various kinds of demands for reporting by different agencies, and we've been trying to correlate workflow with that. So what happens at a peak? how do we address those peaks? How do we be responsive to this? But also, how do we help change the policy so that, these peaks are untenable? Hospitals have suddenly 2 more hours of work daily to do. And in a hospital that is not set up with advanced analytics capability, that's a tremendous, tremendous burden. So one of the goals is to actually affect policy in some way. I know I'm going through this very fast. We've mapped out requirements and we saw the changes over time, and we're looking at the specific requirements and looking for data visualizations and other approaches that might be doing that. Dr. Senathirajah will talk a little bit more about the HERDS report. It's arguably the most important, the most work intensive. Unfortunately, it changes with some regularity. They introduce new questions. Some questions are very straightforward lookups, some are not. And so a lot of this is gathered manually at this hospital, at SUNY Downstate, the safety net hospital. And there's a tremendous amount of daily work involved in putting this together. This is very different from a Columbia Presbyterian Hospital, New York Presbyterian Hospital, which has a dedicated staff of 50 people working in data analytics. And they have much more evolved and sophisticated systems and so forth. They also have a centralized data warehouse, automatically updated, reduces the need for manual searching. They had EMR that generated reports that anyone could access, not just the IT team or specific departments. That's an important point of data analytics. So overall, the goal, you've probably seen this. This is the mission of a core mission of medical informatics. That's gather and aggregate data, translate that to knowledge, and translate it into decisions and actions. And that's the core set of solutions that we're trying to build in. It's really perfectly general. So we put a lot of work into the discovery phase. We're just beginning to work in the solution phase, which involves, we're now at 20 minutes, so I'll bring it to conclusion. Sorry, I was just told it was 10 minutes. So I made the point, safety nets hospital lack needed IT infrastructure and resources. There's a need to mitigate institutional inequities. The discovery phase has really been eye-opening. There's tremendous challenges, but immense dedications. Our objective is that small tractable changes, like a useful dashboard, can make a big difference. We want to contribute to institutional resilience. This is our team. You probably recognize some of these cast of characters, and I'll turn it over to Dr. Senathirajah.
So thank you very much for inviting me, Dr. Kenrick and Dr. Baricki. I'm going to follow on some of the approaches we're taking to trying to solve some of these problems. And so our aims are, how can we create or adapt tools that meet emergency response requirements? And there are many parts to that. How feasible are certain kinds of approaches? What kinds of data aggregation can we do, especially given institutional constraints? Can we have dashboards the way that other institutions do? And how far can these processes be automated? And then testing, what effect do these tools have on actual institutional pandemic response? So as Dave was saying, one of the things we found is that there was a tremendous amount of manual data aggregation. IT staff were overwhelmed. They have few resources, and therefore they couldn't put a lot of things in place. And so the situation was really saved by heroic work among clinicians and others. For example, the infectious disease director spent 2 hours every day putting data into Excel spreadsheets, and when he certainly had other clinical things to do. The emergency department staff set up a spreadsheet system with 10 departments and people from many different units putting in data and using students for data entry. They were tracking a new disease, and so that meant, the kinds of things you wanted to track changed quite often and quite suddenly. And because of a lack of other ways of communicating, They started a huddle system to inform everybody in the hospital. Initially, that was in person, and then they started doing it remotely. And that turned out to be a critical tool for informing everyone, for making decisions, for collecting data, and so on. And so that daily manual data collection spreadsheet was used for decisions. So there's very highly experienced staff, but there was a lack of predictive analytics, nothing like what the other hospital, Columbia Presbyterian, had. And therefore, there were many gaps in communication. For example, unlike many hospitals, the lab system was not connected to the electronic health record, so a runner had to manually run the results between floors, for example. And if that runner person was out, that could mean, up to 12-hour delays. The information system in the emergency department didn't have COVID screening elements, so they had to send people to another building. There was really a lack of integration of different electronic systems. And then when they were integrated, it meant that sometimes specialized functions were lost. So the emergency system before integration, had specialized ED functions, and that was lost. And then there were other things like facility systems, which outside of a pandemic, may be quite fine being separate, but it meant that it was more difficult to manage things like PPE and so on. So for all these reasons, there are big needs for visualizations and displays to show trends, to help detect trends and help make decisions. And so the top level needs were, can we extract information, automation? Can we automate information extraction? For example, just simple patient counts in the early morning were used for decisions. There is a need for situational awareness, especially in an emergency. It turned out that even though there is an electronic health record in place, people wouldn't necessarily know where a patient had been taken, what floor they were on, what were some of their risks, what was their COVID status, and so on. So there's a need for central data aggregation in a database that with visualization tools on top that could be accessed by a number of different people. And of course, there's a need for analytics for emergency response, the way that is done in more well-resourced hospitals. There have been many efforts in COVID visualization worldwide, and these are a couple of examples. So Epinome is a tool made to show many different views for tracing epidemics. And this is the kind of thing that ideally would be incorporated in a safety net hospital. Utah found that because of the many different information sources involved, epidemiologists were getting overwhelmed by different plots and so on. And so they came up with the concept of a sort of epidemiological weather map that would integrate all of those and allow one to visualize things in different ways. And this is an interesting visualization from Google Earth. It's also interesting because it does show a recognizable landscape with recognizable cities. It meets the needs both for having display of magnitude and so on, but also is probably understandable to people with less education in visualization, which is one of the requirements in a safety net hospital. So if we talk about design needs, there's a need to present to decision makers, emergency response, top administrators, and so on. And that brings about the need for simplicity and familiar visualizations or rapidly learnable visualizations. There's a need for having these things be rapidly created and disseminated. And ideally, because of the particular need in this hospital, there were unpredictable and often quite large staff outages that could, you couldn't necessarily predict from day to day who would be out, either because they caught COVID or they weren't able to come into work because of transport difficulties or many other reasons. So one design consideration is, can new displays and new visualizations be created and interpreted by a large range of people? Ideally, there would be automated data collection from all the departments fed into a central database with visualization tools on top. And as well, there's a need to incorporate external data. So for example, New York City Public Health Department was collecting data and making it available. There was a critical need for information about PPE, where it could be available. We found from interviews that stuff sometimes in, as they put it, they were sometimes talking on the phone to quite shady people trying to get PPE. There is a need for AI tools for allowing further and more sophisticated prediction, and the need to communicate with neighboring institutions. So automating feeds to all kinds of reporting, which could be configured as new requirements emerge, was also a very critical need. As I mentioned, the more that tools can be installed and used without IT involvement or specialized training, the better it is for this situation. We also found that in our attempts to create new tools, and it required multi-stage processes with many obstacles, and therefore not necessarily in the sort of direct progression you might expect at other types of institutions. So for example, data in Excel is available, so we can put Tableau on top of it, but aggregating things into a relational database may have to come at a later stage because it presents more resource obstacles. And so consideration of what's more feasible, what's less feasible, what the reasons for it, and having a flexible plan is important. Analytic systems such as Tableau, which I'm sure you're all familiar with, are usable by non-professional end users with some training. Ideally, they should be walk up and use. And it's important to keep in mind in this kind of setting that some users may not even understand simple visualizations like plots and so on. We have to keep in mind that these are learned skills, even though we find them natural. And many people have not necessarily had that education or experience. This is a sort of minor sketch of how we found the system. And as you can see, the orange arrows are manual data collection. So these systems are often not connected at all. But with a few connections, it could be turned into a much more integrated system with much more automation. And ideally, one would create a dashboard, this kind of thing that decision makers could access at any time and use to make predictions and decisions. There's some non-visualization needs. The need for agility is especially important because of the way that the pandemic changed and the way that the reporting requirements changed. Reporting requirements sort of carried extra stress because they were made by governments who could also penalize the institution. So they could call them up at 9 in the morning and say, we want this new data, you have to report it by 1. And you'll get fined if you don't. And so this often imposed a great deal of stress because the institution had to collect that data manually, and definitions were not necessarily that clear. So we also proposed that systems be designed to be very flexible and not necessarily structured around anticipation of specific disasters, but thinking about what systems could be effective and route around them. There used to be a saying, the internet treats censorship as damage and routes around it. So similarly, we need to think about what type of capacities need to be in place, and if they're damaged or otherwise affected, what are the alternate routes? And this can be done by also modeling through software and other means, different kinds of outages and different kinds of responses. So ideally, a system that one is setting up should have maximal information with maximal flexibility and maximal numbers of users able to create and access things. In order to do this, we had to create, sort of analyze what kinds of things could be done, how feasible were they, and we made a distinction between technical feasibility and resource feasibility. And there's also another concept we're using, administrative feasibility, because many things are technically feasible, but really not resource feasible in this kind of setting. And then there can be administrative blocks as well. We found that there can be non-obvious reasons why administrative feasibility can be low. For example, even when the state offered free tools, they were sometimes refused because administrators might desire to not appear lacking or might fear that the reputation of the hospital would be affected. And that has, in the US, that has a direct effect on their finances. There can be sort of concerns about HIPAA and privacy and perhaps overuse of restrictions on researchers. They may just have competing project or financial priorities and feel that, manual aggregation is fine. And also just bureaucracies. This is a state-funded hospital and therefore has many rules and regulations which are not necessarily waived during emergencies. There was institution-specific needs. So one interesting point was that this hospital would keep track of the surges in hospitals in the surrounding area, and they knew that if surrounding hospitals had a surge, they would have one 2 weeks later. They felt there were sort of reasons related to the population about why that might be. I mentioned the need to pull unpredicted data on short notice. What happened in actual practice is that because there was a real need for software and visualizations, people used existing public tools. So for example, clinical coordination was done through 26 WhatsApp groups set up by the clinical staff. There needs to be able to post data of different types to restricted web sites. And there was a need for emergency messaging. Being able to visualize the kinds of constraints, for example, when is this unit filling up? When will we need more beds? There's an emergency set up to shift patients as the number of COVID cases increases and so on. And all that requires messaging and visualization. I mentioned being able to connect tools, and there's an interesting example in the public web. Zapier is an online tool that lets you connect 5,000 different apps for things like personal workflow automation. And we might want to consider something like this in healthcare. So for example, this is a workflow set up from a calendar invite. You can automate it to check whether it's about a podcast and then prepare the document and create a to-do list item to check. And these are all done by ordinary people who just fill out forms. These are some student visualizations who are working on our project. So this, for example, is the maximal hospital inpatient bed occupancy by week and percentage changes from the previous week. This was an important thing that had to be tracked. And the zone in orange is sort of above the maximal number of beds. It was a roughly 200 bed hospital. This is the number of confirmed adult COVID cases by week and by age range. So as you can see, it fluctuated quite a bit depending on whether there was a surge or not. This was an area graph of confirmed cases by average of the week, and it includes vaccination status. That was an important consideration. And this was counts of patients testing positive by age and gender. Again, these are sort of basic statistics, but quite important for decision making. A stepped line graph of maximal hospital inpatient bed occupancy by the week and percentage changes from the previous week. So as you can see, it does fluctuate quite a bit. And the counts of COVID-19 positive tests by age group and gender. This kind of thing was quite important for hospital decision makers and deciding things like allocating beds and keeping track of what needs would be, including needs for things like PPE and drugs and so on. So I wanted to end by making mention of some of our other work, which advocates of flexible and user-controlled information systems in order to let clinical users and other healthcare users create their own interfaces and tools. And so we're taking some of this approach in our current work. So this is an example from a COVID-specific screen for clinical display. And in this system, the end user clinician can drag and drop things and create their own tools. We think it's important to consider how far end users who aren't IT people or informatics people can drive both innovation and creating ordinary visualizations to help with their work. And the role of interoperability, if we cannot connect data systems on the back end, is it possible via front end means such as robotic process automation? Again, in practical terms, we've had to consider how far can we automate things without IT cooperation, which may not be available due to IT staff overload. And then another thing we found in interviewing people is that at both institutions, people didn't really realize what they were going to have to handle, in spite of the fact that some other countries had a 2-month lead. So is there a blind spot there, and do we need to pay more attention to these things earlier? Again, this is our team, the same people with the heads slightly rearranged. Thank you very much.
So I'm gonna kind of go through these slides quickly because I think it's important to leave a little bit of time for questions. My name is Kenrick, Cato, and thank you for inviting me to talk. I'm an assistant professor at Columbia School of Nursing and also clinical informatics. As an assistant professor of clinical informatics in the emergency department at Columbia University and a nurse researcher at New York Presbyterian Hospital. Both David and Yalini mentioned kind of the relationship, the type of difference between SUNY Downstate and New York Presbyterian. And I thought it'd be interesting to talk a little bit about some of the work that we did, that I led here at New York Presbyterian during the surge. So I'm gonna go through the objectives, but basically I wanted to talk a little bit about what we call CONCERN, which stands for Communicating Narrative Concerns Entered by Registered Nurses. It is both a funded study and a series of studies. CONCERN is built as an early warning system to detect inpatient deterioration, and the kind of idea behind it, and it's based on research that our team has done over the last 11 years, is that when nurses use their expert opinion to see that a patient, there are subtle changes in patient state, they increase their observations. And then we can see by looking at interactions of the EHR, this increased concern for patients. And so we use basically changes in nursing documentation and behavior to predict possible patient deterioration. And it's important to point out that we are modeling the clinician and not the patient to achieve this goal. So CONCERN is funded by the National Institute of Health, specifically the National Institute of Nursing Research. It's a multi-site study between Columbia University and Harvard University. And these are roughly the 3 aims of the study over 6 years. And what I'm going to talk to you about is mostly about aim 1, where we spent a couple years at both sites using 5 years of historical data to build, well, we'd already built, but to confirm predictive models. We use natural language processing, where we actually modeled concerning concepts in nursing notes, free text notes, and we use those variables or features in our machine learning model with other structured variables or features to create a predictive model that then did a risk stratification for deterioration. And so in this work, so our overall goal is really to try to increase the overall situational awareness of the whole interdisciplinary team. So while we were doing this work, so myself and Dr. Sarah Rossetti are the multiple principal investigators on the study. We developed a analytical framework that we call healthcare process modeling to phenotype clinician behavior. So basically what we did was we took that approach that I just mentioned and said, hey, we can actually look at, when you look at how clinicians are interacting with a clinical system, we can use their patterns of behavior to phenotype certain things. So we understand that we're using a clinician's expert knowledge and how they try to convey that expert knowledge constrained by that clinical system to understand what they might be doing for some kind of outcome. For concern, it's deterioration, but there's a large list of kind of concepts of interest that you could do this phenotyping for. And so for us, it's important to point out that at every step of the way, it's expertise driven, clinical domain expertise driven. So at every step of the way, we have clinicians giving feedback and helping us do our modeling. So when you think about modeling, one of the things you try to do is find patterns. So I just wanted to show this graph. It's kind of off the screen, but basically what we did was we graphed the different inputs that nurses were doing over a 24-hour period. The y-axis is the probability that event happened, and the x-axis is every hour of the day. So for example, blue is the oxygen saturation observations being entered in the EHR. And you can see, and then this big orange line is discharge. So you can see most people are actually discharged somewhere around 2:30 in the afternoon, or around between 2 and 2:30 in the afternoon. But the take-home point is that there are distributions to nursing behavior, distributions that can be modeled, and the distributions often overlap with the things that we were looking at, which were basically vital sign measurements and medication administration. That's what all these different colors represent. And so we basically took a machine learning approach and decided that because these data are time varying, that we would model every hour of the day. So we created a model, multiple models for every hour of the day for those variables or features. And so these are the kind of large buckets of features that we use in our modeling. You can see, things like we're looking at frequency of vital signs, frequency of comments that a nurse might optimally put in, frequency of medication administration, note frequency. We're using natural language processing to actually look at nursing note content. And this is what goes into the model. And so we were able to produce a set of well-performing models. I mentioned we're modeling and we used this decision tree-based modeling approach. We actually had a couple of different models. We had a generalized linear model, just a vanilla decision tree model, and then a gradient boosted model. And it was the gradient boosted model that performed the best. And this is what you're seeing is the average of all of the models that we have. So we have a set of models for the ICU and a set of models for the ACU or med-surg setting. And we have over 1,200 models when you think that how we broke it up, which is we have a set of models for the two settings, ICU and med-surg, and then we have 24 models for each hour. And then we have different models depending on how long a patient's been in the unit, depending on how long a patient's been in the hospital. And And in our actual live system, it's pulling that patient data every hour and understanding the patient characteristics, like how long they've been there, and applying the actual model is stored in a database, and it's applying the relevant model to that patient. And this is just a average of the performance of all those models. So I just wanted to give you a sense of very quickly of our modeling approach. So, so just shifting a little bit, you saw to COVID, you saw some graphs to show that kind of showed the peak. So this is a graph of the suspected COVID admissions in two of our emergency departments. The different lines are the two different adult emergency departments at New York Presbyterian at Columbia University. And on the x-axis, you have time. So this is March 16th of 2020. You can see that the suspected COVID numbers went on a daily basis very quickly from about 12 all the way up to 90 admissions every day. And so this is just gives you a sense of where we were and what we call the first surge of COVID in New York City. And so we had an operational need from the hospital where they needed to understand, and I think Dr. Kaufman mentioned this, things like bed availability. And so we were asked if we could first identify all the beds in the hospital, because believe it or not, the hospital couldn't identify all of the possible available beds. And that was partly because we were converting beds. We were building units in, for example, surgical bays, in procedure areas, in hallways. So it's hard to know exactly how many beds. And also the level of care that was happening. And the level of care changed. So for example, a bed in a hallway, one day a patient, it could be a med-surg patient, and then the next day, ICU level patient was put in that bed. And so they needed to know on a fairly dynamic way what level of care that patient was getting. So you can see here, these are the different facilities. They wanted to know, whether it's an ED or non-ED, adult or pediatric patient, and then the level of care, where they were, whether in the hallway, isolation. And so we decided to solve this problem, this kind of dynamic tracking, we would use the concern approach. And so what we did was we basically, the features or variables that we used were the flow sheet entries or observations the nurses were putting into the system. And so our kind of theoretical approach was that a nurse would be charting differently, putting different observations in for an ICU patient as opposed to a med-surg patient. And you also saw different patterns if a patient was in the hallway as opposed to in a room in timing. And so this was something that we worked out with the nurses that were working in the hospital at the time. And so those were the features that so when we first started, there were roughly 16,000 different features that were potential features. We actually used a decision tree to do feature reduction to see which features were performed the best for this task. And then we ended up using a multi-class logistic regression model because the need of the hospital was to be able to transfer this information. The need of the hospital was to be able to transfer this information into a report that they could run daily or hourly. And so logistic regression model was the best way to do that. And so we stored the covariates of that model in a SQL database. And so basically when we would run the report, it would just pull the covariates of the model from and look at and run those over the features. And so we were able to, so we did some training on 20 random days. And then we were able to validate the model using additional holdout set. And so we ended up having a very well-performing model that we could then use for that use case. And so I just wanted to point out that the end result was a very well-performing model, but it was also a very scalable model. Because of the way it was implemented, we were able to run it very quickly. The analytics department actually just ended up running it once a day, but you could theoretically run it every 15 minutes. You could run it an hourly for 3 hospitals. And then eventually we ran it for, I think, 10 hospitals in our hospital system. And then we ended up, there was a manual process that was going on where they had nurses and other clinicians going to the units to check on bed availability. And so this report we ended up using it to validate the manual process and using both processes to make sure that the reporting that Dr. Kaufman mentioned was accurate. And then realized it could be applied to other use cases like ventilator use tracking and dialysis tracking, because the documentation for those different clinical situations are very different, and it was easy to find the signals in modeling for those. And so I just wanted to tell you, just a little bit about how we applied some data science methods to produce operational reporting for that situation. And I'd be remiss if I didn't mention our entire concern team, both at Columbia and in Boston. As I mentioned, Dr. Sarah Rossetti is my co-PI on this project. And thank you for your time.